and other free-living staphylococci. Under the microscope, the staphylococci all appear having the same microscopical appearance. They all are gram-positive cocci arranged in single pairs, tetrads, or irregular clusters. الصوت واضح يمكن؟
نعم دكتورة.
Okay. So under the microscope, all the staphylococci are having the same macroscopical appearance, and they are also non-motile, non-spore forming. In the previous lecture, we talked about Staphylococcus aureus. In this lecture, we will continue with the Coagulase negative staph. The overall clinical appearance of infections caused by Coagulase negative staph have been characterized as associated with subacute or chronic clinical courses without fulminant signs, while infections caused by Staphylococcus aureus could be mild skin infection, deeper infection, or life-threatening infections and may even lead to death, while Coagulase negative staph only cause subacute or chronic clinical courses, and seldom they are life-threatening, only in case of immunocompromised patients. First, we have Staphylococcus epidermidis. Staphylococcus epidermidis is a coagulase negative staphylococcus. It forms about 50 to 80% of the isolated coagulase negative staphylococci. Its importance mainly in hospital-acquired infections. So it's a member of the normal flora of the human skin. It can be present normally on the skin, in the respiratory tract and gastrointestinal tracts. It's a non-pathogenic microorganism, non-invasive, coagulase negative, and tend to be non-hemolytic when inoculated on blood agar. This microorganism is always isolated from the normal flora of skin. Infection is predominantly hospital-acquired. Staphylococcus epidermidis is mainly associated with instrumentation procedures, which means that the microorganism is present as a normal flora on the skin. When we don't sterilize the skin and put cannula, the microorganism may enter the body through the process of instrumentation or cannulation, and it may become stuck to the surface of the cannula, forming a layer of biofilm and cause the infection, which is caused by hospital-acquired infection Staphylococcus epidermidis. So the microorganism is a non-pathogenic microorganism and non-invasive, not have an invasive ability. The microorganism is always isolated from the normal flora of the skin, and the infections is predominantly hospital-acquired. The most common hospital-acquired infection caused by Staphylococcus epidermidis are urinary tract infection, prosthetic valve endocarditis, intravascular catheter, and CSF shunt infections. As we see, all these infections are related to instrumentation. Urinary tract infection mainly due to the entrance of the microorganism through the urinary catheter. Prosthetic valve, which is a prosthetic device in the heart, and so the microorganism can stuck on this prosthetic valve. Intravascular catheter, also instrumentation, and CSF shunt infection. Any foreign body instrumentation inside the body, the microorganism may enter and cause the infection. Septicemia only reported in immunocompromised patients. Staphylococcus epidermidis not have virulence factors like Staphylococcus aureus. It doesn't secrete enzymes and toxins like Staphylococcus aureus. The main pathogenic character of this microorganism is the biofilm layer formation. This biofilm layer formation is the key component in the bacterial pathogenesis. What is biofilm? Biofilm is an aggregate of bacteria that are held together by a mucus-like matrix. This mucus-like matrix consists of carbohydrate. It protects the microorganism from the immune system. Also, the antibiotics, when the patient have antibiotics, the antibiotics can't penetrate this matrix. So the microorganism hides itself inside this matrix and exert its pathogenic effect, proliferate and dislodgement of this microorganism to distant area and multiply in other areas. So this biofilm is the key component in the bacterial pathogenesis, which is an aggregate of bacteria that are held together by mucus-like matrix of carbohydrate. They adhere to the surfaces, which could be liquid, solid, or living tissue. Most antibiotics don't work against them because they are hidden, and the antibiotics can't reach inside this matrix. This is an example of hospital-acquired infection caused by Staphylococcus epidermidis. The microorganism is present on the skin as a normal flora, and when they are not properly sterilizing the area during cannulation, the cannula will enter the body in the blood vessel. The microorganism can enter with the cannula and attach to the cannula, forming the biofilm layer, the proliferation of the microorganism, and dislodgement, forming microemboli which go to another distant areas. So this is the main pathogenic character of the microorganism. It doesn't secrete enzymes or toxins. It's a non-pathogenic microorganism, non-invasive. When there is a break in the skin, instrumentation of the body, it will enter and proliferate inside the body. The other Coagulase negative Staphylococcus is the Staphylococcus saprophyticus. Staphylococcus saprophyticus is non-hemolytic. Also, when inoculated on a blood agar, it causes no zone of hemolysis. It causes urinary tract infection in young women. It is the second commonest cause of urinary tract infection. The first common cause is E. coli. The second common cause is Staphylococcus saprophyticus. So it's a true urinary pathogen, and it's rarely found on other mucous membrane or skin surfaces. In urine culture, it may be found in low concentrations, but still considered to be pathogenic. Staphylococcus saprophyticus adheres more than other bacteria to the epithelial cells lining the urogenital tract. It could be present in the urogenital tract, but rarely found in other areas. Now, we have Staphylococcus aureus, which causes different types of infections. Could be superficial infection, folliculitis, furuncle, carbuncle, boil, or other suppurative infections of the skin. The deeper infections caused by Staphylococcus aureus are osteomyelitis, endocarditis, and other infections. The toxin-mediated infections caused by Staphylococcus aureus, staphylococcal food poisoning, toxic shock syndrome, and the scalded skin syndrome. These infections are caused by the virulence character of the microorganism. It have virulence factors, enzymes, toxins secreted, and give the microorganism the pathogenic Coccus aureus. Regarding the Coagulase negative staph, we have more than 35 species. The most important species encountered in clinical sample is the Staphylococcus epidermidis, which causes mainly hospital-acquired infections, and usually it's associated with any instrumentation procedure inside the body: catheter, urinary catheter, venous catheter, cannula, prosthetic device, and any instrumentation, CSF shunt. It will enter the body and cause the infection. Staphylococcus saprophyticus mainly causes urinary tract infection. It has an adherence capability to the epithelial cells lining the urogenital tract. It also not secrete toxins and enzymes. So it's important to diagnose the staphylococci and to identify the species to know the treatment for each condition. The most important thing in the laboratory diagnosis is the sample collection. The sample should be collected properly to get a proper diagnosis and should be transferred without delay to the lab and avoid contamination. Why we shouldn't delay the sample? because the sample may get dry and the microorganism will die on the swab or the sample, and we will not get the correct results. Also, we should avoid contamination because contamination of the sample may give us a wrong result, not the causative microorganism. So the most important is the time should be as soon as possible transferred to the lab, and also avoid contamination. Proper cleansing of the area. If you will take sample from the skin, we should take the sample from the lesion, and we should sterilize the area around the lesion. The transport should be immediately without delay to avoid the dryness of the specimen. After having the sample to the lab, we should do microscopical examination of gram-stained smear. We should stain the smear with the gram stain and examine it, and we will see gram-positive or gram-variable cocci arranged in single, pairs, tetrates, or clusters inside and outside the leukocytes. First, we should collect the sample properly. Second, we do gram stain to the smear, and we will see the gram-positive cocci. After that, the sample should be cultured on different types of the culture media used for the cultivation of the microorganism. We have simple culture media. Example of it is the nutrient agar, and we have the enriched culture media. Example is the blood agar. Staphylococci readily grow on rotting culture medium and the enriched culture medium. So it can grow on simple and enriched culture medium, particularly sheep blood agar. It can grow within 24 hours. And after 24 hours of incubation of the microorganism at 35 to 37 degrees centigrade, Staphylococcus aureus will produce round, smooth colonies with golden pigment on nutrient agar and with hemolytic zone on blood agar. So on nutrient agar, Staphylococcus aureus will form golden yellow colonies, particularly when the culture left at room temperature. On blood agar also will form golden yellow colonies with a clear zone. This is the clear area with distracted RBC due to the production of the alpha toxin by the microorganism, which cause beta type of hemolysis. This is the clear zone of distracted RBC around the colony, and it's caused by alpha toxin, which is caused the beta hemolysis. Staphylococcus epidermidis also grow on nutrient agar and on blood agar. On nutrient agar, it gives us white colonies, and on blood agar, they are non-hemolytic. Staphylococcus citrus on nutrient agar give us lemon yellow colonies, only produced by 50% of the strains. So we cannot depend on this pigment production for the identification of the species. It can give us an idea of the microorganism, but the definitive diagnosis is by further biochemical tests. So Staphylococcus saprophyticus give us lemon yellow colonies. On the blood agar, they are non-hemolytic. Staphylococcus aureus on nutrient agar give us this characteristic golden yellow colonies. Also, this is nutrient agar. On blood agar, give us beta hemolytic colonies. They are golden yellow and beta hemolytic on blood agar. Staphylococcus epidermidis give us white colonies, white creamy colonies. On blood agar, they are non-hemolytic, no clear zone around the colony. And Staphylococcus saprophyticus on nutrient agar give us lemon yellow colony, and on blood agar, they are also lemon yellow in color with no hemolytic zone. So we inoculated the microorganism on blood agar and nutrient agar. The other culture medium used for the identification of the types of Staphylococci is mannitol salt agar. From the name, the culture medium contains mannitol sugar or carbohydrate, salt, high salt concentration, about 7.5% in ACL. Also, it contains a pH indicator. This pH indicator, at alkaline pH, it becomes red, while at acidic pH, becomes yellow in color. The mannitol salt agar is a selective culture media. Why it's a selective culture media? It causes selection of the staphylococci. It can grow on this culture media, while other microorganisms can't grow on this culture media because it contains high salt concentration, which could be tolerated by the staphylococci. Other microorganisms can't tolerate this high salt concentration, so other microorganisms will not grow on this culture media, while the staphylococci can grow on this culture media because they can tolerate the high salt concentration. For that reason, mannitol salt agar is a selective culture media, cause selection of the growth of staphylococci and inhibit the growth of other bacteria. At the same time, mannitol salt agar is a differential culture media, which means that it could be differentiate between the Staphylococcus aureus and the Staphylococcus epidermidis. The Staphylococcus aureus is a mannitol fermenter. When there is fermentation of mannitol in this culture medium, the microorganism will cause production of acid. This acid production will lower the pH of the medium, and the color of the indicator in the medium will change to the yellow. So when there is formation of yellow color, means that there is a mannitol fermentation, acid production, lowering of the pH of the medium, and changing in the color of the pH indicator. This occurs in case of Staphylococcus aureus. While in case of Staphylococcus epidermidis or other staphylococci, the microorganism grow on this culture medium because it can tolerate the high salt concentration, but it is not mannitol fermenter, so there will be no change in the color of this culture medium. Mannitol salt agar is selective for the staphylococci and differential between Staphylococcus aureus, which is mannitol fermenter, which cause the production of this yellow color, while Staphylococcus epidermidis, it can grow without changing the color of the medium, so can differentiate between Staphylococcus aureus and the other staphylococci. This is another picture of mannitol salt agar. We see here the growth of the microorganism without changing the color of the medium, means this is Staphylococcus epidermidis. While in this half of the plate, there is a growth and there is color change at the same time, means the microorganism is mannitol fermenter and it is Staphylococcus aureus. So from this culture media, we can diagnose the microorganism as mannitol fermenter, Staphylococcus aureus, and other staphylococci. For further identifications of the species of the microorganisms of the staphylococci, we need further biochemical tests. First, we do the catalase test. Catalase test is performed on staphylococci, and all the staphylococci are catalase positive. In case of staphylococci, all are catalase positive. Streptococci are all catalase negative. From the start, when we take the sample and we saw gram-positive cocci under the microscope, we might think that they are either staphylococci or streptococci. So when we do the catalase test, we can differentiate between them. What is catalase test and how it is done? This is a slide, and on this slide we add a small amount of the growth or colony on the slide. Then we add a drop of 3% H2O2. The immediate appearance of bubbles on the slide means that this is catalase positive test, while if the drops remain the same without any bubble appearance, means this is catalase negative. So the appearance of bubbles positive catalase, and if there is no bubble appearance, this is a negative catalase test. Positive in case of Staphylococci and Micrococci, negative in case of Streptococci. The other test used for the identification of the species of Staphylococci is the Coagulase test. We mentioned that Staphylococci, according to the Coagulase, are either Coagulase positive, which includes the Staphylococcus aureus only, and the Coagulase negative staph includes the other species of Staphylococci. We have two types of Coagulase, either the slide coagulase, or also called the bound coagulase, and the clumping factor, and the tube coagulase, Staphylococcus. Both are secreted by Staphylococcus aureus. How is done? The slide method detecting the bound coagulase is done by adding a few amount of colony or growth of the microorganism on the slide, on two slides. Here we will detect the negative strain and the positive coagulase strain. Then, after adding the colony of the microorganism, we add drops of plasma on the slide. The appearance of curds or agglutination on the slide after adding the plasma means that this is a positive coagulase test which occurs in Staphylococcus aureus. While if the fluid remain homogeneous and no agglutination or curd formation on the slide, mean this is a coagulase negative strain or any species of the coagulase negative species. This is the slide method. Appearance of agglutination positive. No any curd or agglutination occurs, mean this is negative slide coagulase. The tube method is done on tubes by adding a broth of the microorganism. Then we add over it diluted plasma, and we put the tube in the incubator for 4 hours or overnight at room temperature. After that, we will examine the tube for any clot formation. The appearance of this clot in the plasma means this is a positive coagulase test which occurs in Staph aureus. While if the plasma remains in the fluid state, mean this is a negative tube method. Positive, there is a clot formation, and the negative, there is plasma remain in the fluid state. This is another picture of the slide coagulase. Appearance of this agglutination or curd formed mean this is a positive slide coagulase, while if the fluid remain homogeneous, mean this is negative slide coagulase. In the tube, this clot formation in a tilted tube. This is a tilted tube. This clot formation mean this is positive tube test, and this tube, this means that it is a negative coagulase test. So the identification of Staphylococcus aureus under the microscope, they are gram-positive cocci. When we do cultivation of the microorganisms on different culture media, Staphylococcus aureus on nutrient agar give us golden yellow colony, Staphylococcus epidermidis white colonies, while Staphylococcus citrus 50% of them give us lemon yellow colonies. On a blood agar, only Staphylococcus aureus is hemolytic, while the other strains are non-hemolytic. On mannitol salt agar, all will grow, and Staphylococcus aureus will change the color of the media into yellow color. Catalase tests, when done, all the Staphylococci are catalase positive. Coagulase test, when done, the slide method in case of Staphylococcus aureus and the tube method will give us positive test. For serious infections caused by Staphylococcus aureus, we need a susceptibility testing, which is done either by broth microdilution or diffusion susceptibility testing. It should be routinely done on Staphylococcus aureus isolates from clinically significant infections. The most important thing in infections caused by Staphylococcus aureus is that the antibiotic resistance is very evident. First, staphylococcal infections were treated with penicillins. After that, the microorganism developed resistance to this antibiotic by production of beta-lactamase enzyme, which could be plasmid mediated. And this beta-lactamase enzyme will cause destruction of penicillin binding protein, so the antibiotic is no more effective. After that, the introduction of new generations of penicillins, which are penicillinase resistant penicillins, which can resist the action of beta-lactamase enzyme. These drugs were used for the treatment of resistant infections. After that, the microorganism acquired the ability to resist these antibiotics by having a gene called MICA gene, which produces an altered penicillin binding protein 2A, which make the microorganism resistant even to these antibiotics. The other line of treatment is the vancomycin. Also, the microorganism produce resistant pattern to this antibiotic. So the microorganism is continually producing a new defense mechanism from the used antibiotics. So the resistance to penicillin G can be predicted by the positive test for beta-lactamase. This enzyme can destroy the beta-lactam ring of the penicillins. Approximately 90% of Staphylococcus aureus produce the beta-lactamase. So 90% of Staphylococcus aureus become resistant to penicillin G. So they introduce the nafcillin, methicillin, and oxacillin, which are called also the penicillinase-resistant penicillins. Even to these antibiotics, 35% of Staphylococcus aureus and 75% of Staphylococcus epidermidis become resistant to these antibiotics. This is the agar used for the cultivation of the microorganism for the antibiotic sensitivity. We inoculate the microorganism on the surface of this Muller-Hinton agar, and we place two antibiotic discs on this culture medium, on the surface of the culture medium. After 24-hour incubation of this culture medium at 37 degrees centigrade, we will take the culture and see the resistance pattern. If there is a growth around the disc, irrespective to the presence of the antibiotic, this is the growth of the microorganism around the disc, means that the microorganism is resistant to this antibiotic. While if there is no growth around the disc, this is the inhibition zone. The appearance of this inhibition zone means that the microorganism is sensitive to this antibiotic. So this is resistant pattern, and this is sensitive pattern to this antibiotic. Before the introduction of penicillins, the invasive Staphylococcus aureus infections were fatal in 90% of cases. After that, the introduction of penicillins and other antibiotics decreased the death percent in the staphylococcal infections. With the increased drug resistance to Staphylococcus aureus, we may return to these days. Penicillins were introduced in 1940s, and resistance to it was widespread by 1950s. The bacteria rapidly acquire beta-lactamase enzyme, which make the microorganism resistant to penicillins. It's capable of cleaving or cutting up the drug, making it harmless to the bacteria. Today, more than 95% of patients with Staphylococcus aureus are not cured by penicillins. And to combat this problem, as we mentioned, the drug companies made methicillin, oxacillin, and other penicillinase-resistant penicillins. They became the drug class of choice for treating staphylococcal infections. Even to these antibiotics, resistance to the new drug began to appear within 2 years of their introduction. The methicillin-resistant strains were also resistant to penicillins and other antibiotics. Today, some hospitals report more than 80% of isolated Staphylococcus aureus strains as MRSA. MRSA means that methicillin-resistant Staphylococcus aureus. MRSA, methicillin-resistant Staphylococcus aureus, are now endemic, at many large hospitals, causing hospital-acquired infections. MRSA is extremely hard to control as it has been found embedding a microorganism could be present in bedding, curtains, windows, and can survive a long time. So it could be transmitted directly or from fomites or any inanimate objects and remain free living for long periods and cause infections. The important reservoir of MRSA is the hospital staff, as hospital workers can become colonized with the drug-resistant Staphylococcus aureus on their skin and noses with no symptoms. They are asymptomatic, only carriers of the microorganism, but they pass the bacteria to their patients, and they are resistant strains and cause different types of infection with resistance to the most commonly used antibiotics. Penicillin work by binding to the penicillin binding protein, which is important in the cell wall synthesis. So the drug blocks cell wall synthesis. MRSA make a new penicillin binding protein 2A, which is encoded by MIC-A gene, and are referred to as MRSA, which can make cell wall but no longer bind to antibiotics. The most important thing in MRSA is that previously it was associated with hospital-acquired infections, and now they are associated with community-acquired infections, even infections caused in the community. It occurs more in prisons, military, and athletes. Patients allergic to penicillin or have MRSA are treated with vancomycin. Even to this drug, vancomycin, increased resistance call for the restrictive use of this drug. After MRSA, we have VRSA, which is vancomycin-resistant Staphylococcus aureus. Vancomycin is the drug of choice and sometimes the only drug available for serious staphylococcal infections, and thus the development of vancomycin resistance has been a serious concern. It may be resistant strains may be treated with daptomycin and linezolid. The most accurate susceptibility is done by non-automated method, and detection of these strains should be reported to the Center of Disease Control. Linezolid used to treat new strains of vancomycin-resistant Staphylococcus aureus. It's a new member of the class of antibiotics that interfere with bacterial protein synthesis. Penicillins interfere with the cell wall synthesis, while linezolid interferes with bacterial protein synthesis. So first we have the penicillins used for the treatment of Staphylococcus infections. The microorganism develop resistance by production of beta-lactamase enzyme. Second, in case of resistance to penicillin, we use the methicillin and oxacillin, nafcillin. The microorganism developed resistance by having a MIC-A gene, which cause the formation of altered penicillin binding protein 2A, and the microorganism become resistant to this antibiotic. After that, the introduction of vancomycin, even to this drug, the microorganism, some strains become resistant. So the last line we have linezolid and daptomycin used for treatment of vancomycin resistant cases. It's important to identify the microorganism and identify the species and do antibiotic susceptibility testing in serious infections, because life-threatening infections should be treated immediately. In case of staphylococcal infections, minor infections like boils, carbuncle, and folliculitis, impetigo, could be treated with antibiotic ointment. In some cases, oral antibiotics may be given for skin infections, in deeper infections. Additionally, if abscesses are present, whenever there is abscess, it should be drained. It should be surgically drained. In more serious infections and life-threatening infections like endocarditis, bacteremia, septicemia, treated with intravenous antibiotics. Several different types of antibiotics have been used to treat staphylococcal infections. The choice of antibiotic depends on the type and severity of the infection, as well as drug resistance patterns. So, antibiotic susceptibility testing should be done. The antibiotics most commonly used cephalosporins, nafcillin, oxacillin, rifampicin, and clindamycin. Combinations of antibiotics and other antibiotics can also be used. MRSA is treated with vancomycin, and the treatment of vancomycin-resistant Staphylococcus aureus is by the use of daptomycin or linezolid. This is all about the staphylococci. The epidemiology and control of staphylococcal infections. As we know, staphylococci are colonizers of skin and mucosal surfaces. They are transmitted from person to person, also could be directly introduced into normally sterile sites, such as by surgeon or nurse during surgery. The mode of spread is important in hospitals where large proportions of medical staff and patients carry antibiotic resistance strains in their nose and skin. So, the prevention in hospitals by that the areas at high risk of infection are the newborn surgery, intensive care units, operating rooms, and cancer chemotherapy. The persons with active staphylococcal lesions and carriers may have excluded from these areas. The application of topical antiseptic to nasal or carrier site is important. Rifampicin coupled with a second oral antistaphylococcal drug sometimes provide long-term suppression and possibly cure of nasal courage. So people working at these high-risk areas should be excluded or treated from their carrier state. Now we'll talk about another genus. We finished the genus Staphylococcus, and we will start with the genus Micrococcus. It's less important, but it could be mistaken with the Staphylococci, so it's important to identify them and differentiate between them and the Staphylococci. The genus Micrococcus is found free living in the environment. They resemble Staphylococci. In their microscopical appearance also appear gram-positive cocci under the microscope. They are forming packets of 4 or 8 cocci, usually form aggregations of 4 to 8 cocci, more than clusters formation. Their colonies could be red, also pigmented red, yellow, or orange. They are saprophytic microorganisms, which means that they are present in the environment or on the skin without causing any type of infection. Present saprophytic in the environment. Only in case of immunocompromisation, it can cause serious infection. They are catalase positive, like the Staphylococci, modified oxidase positive, unlike Staphylococci. So, oxidase test used to differentiate between micrococci and Staphylococci, and they are Bacitracin sensitive, unlike the Staphylococci. So, when we have a gram-positive cocci in the sample, first we do catalase test. If it is negative, mean the microorganism Streptococci. If it is positive, either staph or micrococci. We do the modified oxidase test. If it is positive, mean the microorganism is Micrococcus. If it is negative, mean the microorganism is staph. And the Staphylococci are differentiated by the different biochemical tests, including the Coagulase enzyme. When it's positive, Staphylococcus aureus; negative, other Coagulase negative Staphylococci. Any question about the lecture or the previous lecture? if there is no question, we can end this lecture, and good luck. I will wait for 15 minutes to listen to your questions, and if you have no questions, you can leave. Thank you.